It is Friday. Welcome everybody to our Lunch and Learn. While we're not together, we're apart. We're learning together every Friday from 12 to 1:30. I am so appreciative of you choosing to spend your time with us on Fridays. And today we have a couple of very special guests with a great topic that we're going to be exploring, which is really the connection between peer support, understanding health disparities, and promoting health literacy, particularly among people that are marginalized and have experienced emotional distress and labels of mental illness. So I am excited that we are getting into our series on understanding physical health. This is Shireen Carrico. I think we have Lynn with us. Lynn, you're here. People have to hear your voice just for a little while, Lynn. Welcome.
Here, and gratefully so.
Thank you so much. And we have two special guests, Martha Barbone and Pamela Goodine, and I'm going to ask them to introduce themselves just a little bit later because I'm going to be handing it off to them after a few slides. So we are, as customary with our Lunch and Learns, please actively participate, use the chat to ask questions, to answer any questions. Silence is not golden in this series, and I am glad you're able to join us on this wonderful Friday. Couple things about Peer Voice North Carolina. This is our statewide movement to mobilize those of us that have lived experience of labels of mental illness, mental health, emotional distress, and connected social justice and social determinants of health. We do a lot of different projects and initiatives with Peer Voice North Carolina. If you're not connected to us, if you're not up to date on what's happening with PVNC, please join our Facebook page. The link is to the right. We update it every week with the most up-to-date information on what we are doing in North Carolina. Our Survey Monkey is also linked there. So if you are interested in receiving emails from us and receiving things like different projects, different opportunities that are coming up, newsletters, please feel free to fill out the survey. And we do have a YouTube channel, Pure Voice NC YouTube channel, that is linked down there. The recording of this Friday will go in there and just make it accessible for us to go back and re-listen and take a look at the resources. So PVNC organizes in part through topic-based collaborations. We have a list here of a few of the collaborations that we have going on, our coalitions. Our Peer Justice Initiative is a group of people that have been incarcerated, that have become peer support specialists, and they are working together to bring a specialty credential into North Carolina for forensic peer supporters. Our Peer Wellness Center pilot, I was hoping to have updated information for you today. I say that every Friday. They still have not announced who is receiving the funding for that pilot, the two pilots and the incubator, but as soon as we hear the information, we will definitely share it with you. And our Recovery Alternatives to Forced Treatment, our RAFT group, is all about looking at the instances of forced, involuntary, and coerced treatment in the name of mental health, looking at policy-related issues, social issues, practice-related issues, and finding ways to create alternatives to forced treatment that really does honor our experience, that is resilience promoting, trauma informed, and voluntary. So I won't read through all of these, but I highlight a few different ones at different times on Friday. Our newest one is the I'm In Community Inclusion Project. Hopefully I can share more updates with you on that in coming weeks because there's a lot of work going on around the Community Inclusion Initiative. The most recent thing that I wanted to share with you is that we did a PSA called My 5 North Carolina. It is actually a challenge to everybody, seeing if we can reach out to at least 5 people 3 times a week for 1 month. We know that connection saves lives. We know that isolation can lead to a lot of emotional distress. And we want to be able to make sure that we stay connected during this time period. If you look on the top, this link with the Vimeo, the PSA, if you link that, you will be able to see it's like a 3-minute PSA. And if you go to hashtag My5NC, people that are taking this challenge are connecting with us and letting us know how it's going. So I just wanted to share that with you. Feel free to forward this to family and friends and others that you think would be interested in learning about that. We are continuing our work around peer support and making sure that we create standards for peer support specialists in the profession. In North Carolina, we have a draft of policy language that could potentially become a bill and a statute in North Carolina. So we are working through on the legislative piece, what that is going to look like. And it is going to be open for public comment, a 30-day public comment period. So we will let you know on the PVNC website about that. And then we're continuing with our training and our TA and funding for consumer-run organizations. The last thing I just want to remind you all is that September is Recovery Month. We have 2 films that we are showing in September. September 12th, we are showing The S Word, a documentary about surviving suicide attempts from the vantage point of survivors. We have a panelist afterwards, which is really quite a great combination of different types of lived experience. And then on September 20th, we're showing the film Medicating Normal, which is the intersection between pharmaceuticals, trauma, military-based trauma, gender identity, race, in suicide attempts. So I'm hoping that you all will join us for those 2. We have some great national sponsors, some North Carolina sponsors, but if you're interested in tickets, they are still up for sale, and the links are on the next 2 slides. So with that all being said, I want to welcome Pamela and I want to welcome Martha, our special guest for today, that will be helping us walk through really kind of a perspective on physical health, the connection between physical health and emotional distress. They're going to be sharing some data and some research, talking about health literacy and how peer support specialists and peer supporters can support people to navigate systems and have access to some assistance that they need around health to become physically healthier. So in saying all of that, I want to welcome Pamela. I want to welcome Martha. I'm going to mute myself, and it is all you 2.
Thank you very much, Shireen. It's so happy to be here. This is Martha, and I just I'll put in a plug for Medicating Normal. It's an amazing film, and I'm very good friends with one of the featured people. So I encourage you to see that if you can. But today, Pam and I are happy to be here to talk to you about peer support services that are used to address physical health and wellness needs of people who live with mental health challenges. This presentation was developed by a dissemination team that was comprised of leaders from the Chicago Health Disparities Center, at the Illinois Institute of Technology, and the National Association of Peer Supporters. The Chicago Health Disparities Center is a group of investigators and persons with lived experience that examine the health and wellness needs of people with mental health challenges. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the effects of stigma on health conditions for persons with lived experience. The National Association of Peer Supporters is a national organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems. And this quote on this first slide sort of leads, this is based on a view of hope and recovery. Believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle. And that was by Christian D. Larson.
Hello, everyone. Thanks for having us here, Shireen and Lynn. I'm so excited to be presenting on this topic with Peer Voice North Carolina. Just to tell you a little bit about myself, my name is Pam Goodine, and I am a person in long-term recovery who lives in Winston-Salem, North Carolina. I'm a strong advocate for the role of peer support, and I currently work for the Forsyth County Department of Public Health Stepping Up program. I'm also employed at Green Tree Peer Center part-time. I'm a route facilitator as well as peer support trainer, and I have worked in many capacities supporting and providing peer support specialist work. And this presentation will review the value of peer support providers based on PCORI-funded research in assisting people with mental health challenges in attaining their health and wellness goals. So again, thank you for allowing us to present today.
Thank you, Pam. And I'm Martha Barbone. As I said, I was in the Air Force for 12 years before I was sidelined by a diagnosis of depression and PTSD. And I was in treatment for a long time, had access to all kinds of care. But it wasn't until I'd been in treatment about 14 years that I found peer support. And that was the first time that I actually had hope, and I found more hope and empowerment through that. I've been a peer specialist on an inpatient unit. I facilitate groups in the VA. I worked for a peer-run organization. I actually followed Lynn in the state of Massachusetts to coordinate the peer specialist training. And most recently, I was a staff member for the National Association of Peer Supporters. I became interested in research after I made the transformation from merely being a recipient of services to being an active collaborator in my treatment. And I look forward to sharing information on participatory research with all of you today.
Okay, so again, this,
Sorry, I skipped it because you already said it.
oh yeah, that's right. So let me just let you all know that we have nothing to disclose or no conflicts of interest. Okay, so the Patient-Centered Outcomes Research Institute is also known as PCORI. PCORI helps people make informed healthcare decisions and improves healthcare delivery and outcomes by producing and promoting high integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. PCORI is a United States-based non-governmental institute created as a result of the 2010 Patient Protection and Affordable Care Act, also known as the ACA or Obamacare. Development of presentation materials as well as the Speakers Bureau during this presentation is made possible by a Eugene Washington Award dissemination initiative proposed by the Chicago Health Disparities Center and the International Association of Peer Supporters. And let me just say that it's now called the National Association of Peer Supporters. So all materials and comments in this presentation are solely the responsibility of the dissemination team, the Chicago Health Disparities Center, and the National Organization of Peer Supporters. PCORI is not responsible for the presentation of these materials.
So why are we here? Why are we talking about this? And this is what we hope to discuss today. First, we're going to talk about the physical health challenge of people that also have mental health challenges. And then we're going to move into introducing peer support as an effective solution or effective bridge to produce better outcomes. We'll briefly describe what community-based participatory research is, and then we're going to show you 3 PCORI research findings that demonstrated better outcomes when peer support was paired with treatment as usual. And we hope to have plenty of time at the end to discuss how to move forward.
Okay, so health providers have often used an illness or maintenance-based idea that made the course of mental illness worse. Perhaps most prominent among these is that those with MH challenges do not recover. The expectation after the diagnosis was that the person would get worse, only to live out the rest of their life in a state psychiatric hospital. This resulted in a lack of hope, suggesting to them that they are not going to get better and should ignore goals related to education, work, independent living, and relationships. Research has shown that this is not the case. We have shifted to a recovery-focused approach that emphasizes those with MS challenges do realize many of their hopes and dreams, even if some symptoms do remain. Effective programs and providers embrace approaches that promote hope, and they do it by empowering, connection, and collaboration. People with lived experience determine for themselves what services they wish to pursue to address their goals.
So we're going to move now into the first part of what are the physical health challenges. And just if you think for a moment, think before I click the button, what comes to your mind of the physical health challenges of people that also have mental health challenges? So as you can see, physical health problems are in almost every organ system. I think the first things that come to my mind were obesity, which often leads to things like high blood pressure and cardiovascular disease. But people can also have gastrointestinal disorders, like we hear often with, ulcers or IBS. People are also more prone to orthopedic injuries, things from falls, because they're not as stable on their feet. And what's been very evident with this pandemic that we're in right now is this population is also more adversely affected by infectious or communicable diseases.
Okay, so the community is at greater risk during the COVID-19 pandemic for many reasons, in which we will discuss. COVID-19 is a viral infection that causes respiratory illness that, when severe, can lead to death. People all across the United States have had to institute precautions to keep from being affected by the disorder. This includes sheltering in place, maintaining 6 feet social distance, and wearing masks in public. If a person believes they are infected, they should promptly be tested from a qualified medical professional. If they are positive for the infection, they should then receive treatment from the medical professional. Sheltering in place has led to significant stress and social isolation, which may worsen the mental health of people already vulnerable to psychiatric illnesses.
Shireen, I can't advance anymore. So we know that these kind of physical illnesses left untreated can cause negative results. People with mental health challenges use the emergency room more often than their peers for physical health problems. They often become disabled due to limited mobility, along with the inability to meet personal goals related to education, work, or independent living because of the physical illness. They often may end up in an institution, and despite the fact that many state hospitals have faded away because of deinstitutionalization, many people may end up in nursing homes or other 24-hour care centers where they get the care they cannot provide for themselves. And as we know, this group often dies, and data is anywhere between 10 and 25 years younger than expected.
Okay, so in addition, physical illness undermines wellness. People living with serious mental health challenges report a lower quality of life because of sickness. Many are less satisfied with day-to-day activities. They report a lesser sense of peace, serenity, and calmness. They state experiencing a feeling of inadequacy rather than a sense of wholeness. We do not mean to say illness and wellness are separate experiences, but that they are treated separately, rather they exist on the same continuum.
So we put this in here as part of we often see it referred to as, what do we mean by serious mental illness? I kind of don't like those words, so I changed it to be transparent. But the definition is a diagnosable mental, behavior, or emotional disorder that causes serious functional impairment that substantially interferes with or limits one or more major life activities. That's the SAMHSA definition. People with mental health diagnosis often also have substance use issues due to alcoholism or other drug use. A mental health challenge can lead to disability by having difficulties achieving personal goals related to education, work, independent living, relationships, or health. And this is a little different than the Social Security Administration determination of disability solely on the basis of employability.
Okay, so what contributes to worse health outcomes? The problem of illness and death among people in this group is worsened by several things. People of color with serious mental health challenges are likely to show more illness and earlier death. People who are poor have worse health outcomes, especially if they are homeless. Crime worsens health. Crime victims get sick more often, but so does the person who commits the crime, especially if they have become involved in the criminal justice system. Excessive use of alcohol and other drugs worsens health outcomes. So we have several things that do contribute to worse health outcomes.
So we're going to go through 6 areas, and the first one is lifestyle. These are typically modifiable health risks or behaviors that make health outcomes worse. People often fail to eat from healthy food groups and actually make health worse by poor diets that are high in fats, sugars, and fast foods. People not only need to know what foods are healthy, but they need to be able to access these foods. People often are more sedentary, and this can worsen health. Cigarette smoking has been clearly shown to be detrimental to overall health. Also, unsafe sex and other behaviors can lead to infections such as hepatitis B and HIV. And we know alcohol and other substances can worsen many physical illnesses.
Okay, the second point that we will touch on is the social detriments. The social detriments of health are particularly important in determining the experiences of persons living with SMI challenges. These experiences may lead to trauma, which can further worsen if the person's physical and it can further worsen the person's physical and mental health. Many people with mental health challenges because of their illness have a limited income and become poor. Poverty at its worst causes homelessness. Many people do not have a regular place to reside or housing security. They may couch surf, live in abandoned buildings, or live on the streets, using shelters only when the weather is overwhelming. This group is more often victims of crime, especially robbery and assault. They may also be more likely to experience domestic violence, most typically violence and assault from a family member or a lover or a friend. This group also has more interactions with the law. Some of them end up in jail or prison without receiving adequate treatment or support.
And the other thing I would add on there is there's often distrust of the system due to past negative experiences. The next area is insufficient resources or a fragmented health system. Sometimes health and wellness are lacking because the community lacks the kind of resources it needs to provide quality care. Primary care clinics that are the entry into health care may not be in the neighborhood. Often clinics that are available cannot be easily accessed. This may be due to a lack of transportation, especially affordable public transportation. Insurance coverage, especially public insurance, is often lacking for needed and desirable services, so patients cannot access or pay for care. Parity in insurance is equal pay for physical health and mental health care. Parity is often lacking, so the quality of mental health care lags behind physical care. Recovery resources are often absent altogether. Together, these problems describe the fragmented healthcare system.
Okay, the fourth point is lack of culturally relevant services. Many service centers and providers fail to address the needs of people in that community. Specifically, clinics are not in ethnically diverse communities. They may lack service providers from ethnic groups of color that reflect their community. People want to receive care from someone that looks and talks like they do. This helps build trust in the system. Often, healthcare services fail to reflect cultural priorities that reflect recovery and hope for this group.
So, and we would be remiss if we didn't talk about medication. And even though this slide says medication side effects, it's just medication effects. All medication has some kind of effect. They have the desirable effects we want, and they have the undesirable effects, which we often refer to as side effects, but they're really just all effects. And some that we see is that these medications, especially psychiatric medications, contribute to significant weight gain. This can lead to type 2 diabetes and high blood pressure and cardiovascular disease. There's other psychiatric medications that cause kidney disease. So patients and their provider team need to work closely to address these unwanted effects and balance these with symptom reduction and with the person's truly informed consent.
Okay, and the sixth reason why this occurs. Some with serious mental health challenges have genetic predisposition or tendency to develop serious physical illnesses, such as heart problems, autoimmune diseases, and diabetes.
So we don't want to be all negative. There are treatments for most of these health conditions we talked about. There's research evidence that shows specific interventions are effective for specific illnesses. For example, we know there are effective medications for high blood pressure or certain cancers, and there's therapy for a broken or a twisted ankle. We also know there's top quality training programs for doctors and other healthcare providers to learn to treat these problems. Hence, there are healthcare teams that have mastered effective treatments that can help people deal with physical illnesses. The problem is that many people living with mental health challenges are not able to take advantage of these teams and treatments. One reason is because the perception that physical health teams are often unable to work well with people living with a serious mental health condition.
All right, so we just reviewed the size of the concerns related to physical health and those living with mental health challenges. Let's now consider some solutions. Specifically, we'll talk about the benefits of peer support services. In the next several slides, we will summarize different versions of peer support providers. First, however, we summarize what is known about good treatment as the foundation on which peer support providers do their work.
Oh, and part of this is this promise of integrated care. And I've heard North Carolina is now moving toward integrated care. The problem without integrated care is that mental health and physical health systems are separate. Integrated care is a solution, one place where the individual can receive all health services, physical health and mental health. There's one team that is able to address both. There's one place for primary care, specialty care, and mental health care, and peer support should be included. Integrated care is a good idea, but not yet fully a reality. One reason may be that healthcare providers resist the call for integration. There may be providers who think I was not trained to work with people with mental health challenges. The second reason is that insurance and government programs have not fully bought into the idea. They've not encouraged health providers to join together into an integrated approach. But now we are seeing some insurance companies have increasing interest in developing models that employ one single care manager to coordinate the care for a range of medical and mental health problems.
Still, integrated care is rising so that it is becoming more common. Hence, we believe that peer support services can assist people living with mental health challenges achieve their goals by coordinating care. What do we mean by peer support providers? These are full and part-time employees who may or may not have a professional degree. They have lived experience with mental health challenges and often come from similar ethnic communities. They focus on hope, strength, and recovery. So peer support workers are people who have been successful in their recovery process, who helps others experiencing similar situations through shared understanding, respect, and mutual empowerment. They may provide practical assistance and support to individuals achieving their own wellness goals.
So we'll briefly go over the basic values of peer support, and I think our audience is well versed in these, but we're recovery focused. We're hopeful and supportive of personal aspirations and choice. The focus is on the relationship. There's no force or coercion in the relationship. We promote empowerment in life in general and more specifically in regards to healthcare decisions. We support people to identify ways to achieve their health and wellness goals they choose for themselves. And support is often provided in the community, but it can occur in any setting.
Peer support specialists share selected aspects of their life with the person they are supporting. This sharing establishes credibility and rapport. It also provides an opportunity for persons that's being supported to learn possible ways they might deal with health concerns. This self-disclosure is often referred to as sharing one's story. The story includes some of the challenge one has faced. This is not a life story, and the peer supporter always can choose what to share or not. For example, many peer support specialists would choose to never disclose the specifics of a life trauma. Second is their journey of recovery and who and what has helped along the way. Peer support specialists want to share their experiences with hope and aspirations. They want to endorse the importance of empowerment and self-determination in their life. Sharing what's worked for me or what's worked for others that I know can be very helpful. The persons being supported might learn concrete ways to address some of their needs. There are limits to self-disclosure. Peer support specialists must attend to whether disclosed information is helpful to the person they are supporting or whether their experience is irrelevant.
So what can peer support workers do? And specifically in this presentation, we'll talk about these three things. But first is supporting shared decision-making, and I choose to call it supported decision-making because as a peer specialist, I'm not making any decision for the person. I'm supporting them to make decisions. And that's supporting them in considering treatment options and in choosing those options that best meet their own personal goals. Second, may be to teach skills and provide concrete information about behaviors that help people self-manage their own health and wellness goals. And the third is navigation. Peer specialists may actually walk the person around a complex healthcare system.
Okay, so I would like to describe shared decision-making a little bit more fuller. Good healthcare focuses on hope and possibilities, not poor prognosis and bad outcome. Self-determination is the key. Namely, persons being supported decide for themselves what their healthcare goals are and how they might be achieved. They desire personal empowerment so that they can make informed decisions. There is a stigmatizing belief that people with mental health challenges are unable to make decisions like these, that congenital disabilities, for example, prevent them from being clear-headed and sorting out evidence for the best decision. This belief is wrong, and peer support specialists are in the best place to challenge it.
And as we said, the peer supporter does not make the decision, but supports the person by helping them understand what the healthcare provider may have said by using non-clinical everyday language. Often people with mental health challenges need basic information about specifics regarding their illness and wellness goals and corresponding treatment options. Peer support can help people create questions to ask their providers and role play visits with providers to empower people to be more comfortable in these situations. On this slide are some examples of questions you might go over with someone before an appointment, so they are clear themselves of what they want. We support people in creating wellness goals as well as concrete ways they might be achieved. I really like the World Health Organization's definition of wellness, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
Okay, so people living with serious mental health challenges can benefit by learning about specific behaviors that might help them attain health and wellness goals. So peer support specialists also teach skills for self-management. That might include stress management, behavioral strategies such as meditation that decrease the anxiety of a situation, medication management, sometimes focus on medication administration and track side effects, healthy eating strategies, activities that help people reach their exercise goals. So there are several skills that a peer support specialist can teach the person that they are supporting.
And we definitely help people make social connections in the community of their choosing. In addition, people can be supported to achieve health and wellness goals by supporting them to locate services, creating questions, and even accompanying them to appointments if they wish. And that's not to speak for them, but just to support them to be heard in that appointment. We may go shopping with them in their neighborhood for healthy food, and we may participate in wellness opportunities with the person in their community. Among many services, peer support help people to do the basic tasks of navigating the system and the community.
Okay, the peer support specialist has several sets of skills that assist in supporting a person so that they better understand their health and wellness goals, as well as strategies to achieve them. Active listening skills are basic to all of these. Active listening skills are a set of principles and practices that allow peer support specialists to be present for the person and share with him or her the peer's perceptions of what the person is saying. The goal here is to promote recovery, hope, and empowerment. The next step may be goal setting. Using active listening, the peer support specialist helps people make a list of goals they wish to pursue in terms related to health and wellness. Motivational interviewing is one way to promote goal setting. In this task, the peer support specialist assists people in analysis of the pros and cons of a specific goal so they can better understand what needs to be done to achieve it. For example, if the goal is to eat a better diet, pros might include possible weight loss, better able to complete daily tasks, and increased self-esteem. Cons might include not being able to eat French fries as much as I like and having to travel across town to a store that sells fruits and vegetables. And advocacy, teaching those that we're supporting how to speak up for what best works for them.
So, and just to bring it back to what we're doing now, how does this apply to the situation we're in right now with COVID-19? And it might continue into the future. Most likely, our work was initially done virtually, and now we're seeing some return to in-person, but there's still a lot of virtual peer support. Peer support can encourage people to shelter in place as recommended by the local health authority. Peer supporters can also discuss fears and uncertainty and offer helpful ways to manage these feelings. We're also sensitive to worsening mental health symptoms among people that we support, and we can help them access and use their own recovery plans.
Okay, the third objective is program development through CBPR. So we're going to address the role of research in program development. A special interest, here's the role of community-based participatory research and program development relating to public health goals.
Community-based participatory research, CBPR, is based on the insight that programs that are developed for a specific community must include individual users of health services that are from underrepresented groups in that community. CBPR is collaborative, where a group of people work together and everyone on the team has a voice. Everyone brings unique strengths and specific expertise. The community decides what is most important to them. And the goal is to improve communities. By hearing the voice from communities, CBPR combines knowledge and action for social change to improve communities. And it also helps to eliminate disparities through the involvement of underrepresented groups on research projects.
Okay, so Inspiring Change is a project that was created to address healthcare obstacles by involving African Americans with mental illness in all stages of the research process. This program was developed in 2015 through a grant sponsored by PCORI, completed by the Chicago Health Disparities Center. This manual comes with a workbook also.
And you can see on this topic some of the topics that they discussed, where they were training people with lived experience to assist others in their community. And this was a 2-day training. The leadership training program focused on the development of skills which people with lived experience might use in order to participate equally on a CBPR team. Our final area is going to be discussing 3 PCORI research studies. And this slide, I know it's very hard to see, but there's actually 5 studies that addressed peer support and physical health outcomes, and 3 of them are complete, and those are the ones we are going to discuss.
Okay, so this is the first PCORI funded study that we're going to review, conducted by John Break from the University of Southern California, titled, Can People with Serious Mental Illness Help Peers Manage Their Health Care? The project tests the BRIDGE program compared to treatment as usual services. The BRIDGE program seeks to improve health care access, utilization, and its impact on self-confidence in managing one's health, as well as overall health concerns. BRIDGE did this by having peers, people in recovery from mental illness, teach research participants health management skills. So the targets of the BRIDGE program was healthcare access, utilization, and outcomes, taught skills to better avail health care with manualized program, augmented by motivational interviewing, psychoeducation, modeling and role paraprofessionals, training done on vivo, peers, people in recovery who were teachers, and it was a 6-month program. The BRIDGE program has a manual also that was used to implement the intervention. This intervention is augmented by motivational interviewing.
So in this research program, there were 151 people that were randomized to mental health care as usual, which is the control group, or BRIDGE plus mental health care as usual. Data was collected at the baseline at 6 months and 12 months. And the measures included the number of routine visits and screenings as an indication of engagement, and participants' perception of their relationship with their healthcare providers. There was also self-reported confidence in self-management, which was their sense of confidence in making decisions about their health. Two sets of health concerns were assessed. Chronic disease was the degree to which participants were concerned about ongoing and persistent physical illness. And the second was their overall perception of bodily pain.
Okay, so this graph shows change in perceived confidence in managing one's health. Notice significant improvement for people in the bridge group, while those in the control group actually show worse confidence. And I'm going to ask Martha to explain the graph itself.
The middle graph shows us changes in concerns about chronic disease, and the last one is reported bodily pain. So in the one in self-management and concerns about chronic disease, you can see the bridge group, which is the solid orange, showed significant improvement. The bodily pain severity is reverse scored. So actually a negative change score means less perceived bodily pain. So once again, you can see significant improvement or less bodily pain for the bridge group as compared to the control group.
Okay, thanks, Martha. The second PCORI funded study was conducted by Dr. Patrick Corrigan from the Illinois Institute of Technology, titled Peer Navigated Support for Latinx Patients with Serious Mental Illness. In an effort to be fully transparent, Dr. Corrigan, the PI of this award that we are highlighting, is also the PI of the overall dissemination grant support in our presentation today. This study developed a peer navigated program called PNP using community-based participatory research. A manual was adapted to train Latinx with lived experience to become peer navigators. In this case, peer service providers were Latinos and Latinas in recovery and living with a serious mental health challenge. They helped research participants to better engage in health services. In this process, research participants were expected to better address their health goals. The key element of this peer navigated program was to literally walk these service recipients around the complex and fragmented healthcare system. The peer navigated program was a 12-month program that collected data at baseline at 4 months, 8 months, and 12 months.
So in this study, there were 110 people assigned to either the PNP group, which was the group that received peer support, or to integrated care as usual, which was the control. Two sets of measures were collected. First, service engagement was assessed by counting achieved appointments each month. Second, perceived effects on health were measured by self-reported recovery, empowerment, and quality of life.
Okay, so this last graph shows change in quality of life from baseline to 12 months. Once again, steady and significant improvement is seen in the PNP group, while quality of life in the ICAU group, control group, did not really change.
And in the top left, the graph shows the self-reported recovery. And in the top right, it's the self-reported empowerment, which is again, one of these that's reverse scored. So actually going down is a good thing. So in all three of these areas, the group that received peer services in addition to treatment as usual had better outcomes.
Okay, this last PCORI funded study was led by Sherelle Bellamy from Yale University and is called Does a Peer-Led Program with Wellness Coaching Improve Wellness Among People with Serious Mental Illness? Using community-based participatory research, this group developed a peer-led wellness coaching program. The PWLC was a 6-month program and included 3 months of peer-led groups, educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individuals wellness coaching offered by a peer provider.
There were 74 people participating in this study that were assigned to either the PWLC, which was the peer support group, or the treatment as usual. 5 sets of measures were collected, including the number of emergency room visits, participant reported changes in alcohol use, general wellness measured how participants perceived their overall wellness, and the last 2 were self-reported input into treatment plan and self-reported satisfaction with treatment.
Okay, so this graph does not represent exact data, but demonstrates the general trends between 2 groups. Compared with participants who receive usual care, participants in the program show fewer psychiatric or substance abuse emergency department visits, greater decreases in alcohol use, greater improvements in general wellness, more treatment plan input, and greater treatment satisfaction.
So, and I'm going to leave this up here just for a minute, but for those first 2, if you go and visit directly these sites, the manuals they used are there. And the one the Chicago Health Disparities Center did is also available in Spanish. I actually will send, or Shireen's going to make a PDF of these slides, I believe, and these links will be active in that PDF. So moving forward, we hope to involve you in a discussion of how to address the dissemination, implementation, and sustainability of issues we presented. There are barriers to this. The data we presented shows how peer support combined with treatment as usual increases outcomes, but still it's not readily available to anyone who wants it. This would require a shift in practice culture. And this is a shift from the providers, and there might still be some who believe that peer supporters cannot be effective employees or do not want to work with us. It also requires a culture shift from people receiving services. I think as a culture, we've gotten used to, hey doc, this is what's wrong, give me a pill to fix it, and I don't participate in that. I'm just a recipient. And we need to encourage people that it's a collaborative effort for the best outcome. We also need to know how to identify and select this workforce, train and certify them, supervise them, and evaluate the program. And finally, how are we going to pay for this? And that's always the big thing. Where's the money going to come from? And sometimes we have to get creative. So with that, we want to turn it over to questions, and they can be anything about what we said or sort of those last ones, these last areas. If you have something to say in that.
Yeah, so if people want to either unmute yourself or ask questions in the chat, that would be great. While you're absorbing all this information, I just wanted to share, because there's a group of people that are on this call that have been working together now with the Lunch and Learns that are part of a Pivot grant, which is an integrated care project here in North Carolina that is federally funded. So I think we have 4 or 5 peer support specialists on the line that are working in integrated care settings. And part of our work together over this next year is gathering this type of information, gathering the data, looking at tools, trying them out in real time as peer supporters. And then ultimately in North Carolina, we're going to be creating a specialty credential for peer support specialists working in integrated settings, because part of the concern is that we do not want peer support specialists to be turned into a role that we were not designed for. So there's a lot of intentionality in this project to make sure that we are not turning peer support specialists into health workers. We're not turning peer support specialists into case managers. We're not taking on clinical tools and approaches and incorporating them as peer support specialists, but it really is requiring us to examine the information that we have available, combining it with in the moment work that many of you are doing right now in integrated settings, so at the end we can create something that makes sense for peer support specialists working in North Carolina in integrated settings. So Martha and Pamela, that's just an FYI for you to know that this group is working on this initiative as we speak.
Wonderful.
It's great to hear, and it's great to hear that you as peer specialists yourselves are involved in what that's going to look like, instead of what's often happened is someone else that's not a peer specialist decides what we should do. And I don't think in most professions that happens. So I'm so happy to hear you are taking the lead on this.
Yeah, this group is actually the group that will be designing it.
That's wonderful.
So that being said, questions, ideas, thoughts in the chat. I apologize if you hear barking in the background. That is my dog trying to give her 2 cents into this conversation. But for those of you who are on this call, what are your thoughts around all of this information, your experience as people that are in recovery that have experienced potentially physical health challenges as a result or connected to mental health? And what are your thoughts as peer support specialists working in health settings?
Hello, I want to speak.
Yeah, please.
Hi, this is Cedric Court, and just to answer your question, I think that the role of peer support in health settings is definitely would be very important or very helpful for people that we support, because through my experience, I know just current experience, an individual that I'm working with, he really needs the help with as far as advocating for what his health needs are to his doctors, and we had that conversation about really explaining to the doctors what you're feeling, really explaining, how things are making you feel, what your body is telling you. And so I just think that it's very helpful through that experience. It's just very helpful helping people and supporting people navigate the medical world, because you can easily get lost in that world sometimes. So it's just helpful having that support there. Does that make sense?
Yes, definitely.
Yeah, it's kind of like being a bridge, or even in some ways an interpreter, because the medical community has its own focus and language and process and culture. And
Right.
sometimes we're just so used to coming in, I think, Martha, that you said, as passive recipients of services in so many ways. And quite honestly, we're taught to do that as people that come into mental health services. We're taught to be compliant. We're taught to be silent. We're taught to just do what we're told to do. And what we have learned both in mental health and in physical health, that active wellness self-management is how we actually recover. But if we don't understand what is being communicated, or we don't have the language to communicate effectively with our doctors, we're back in that position of being silent, passive recipients of service and not actively involved in our medical care. So I think that makes complete sense, Cedric.
Yes, thank you. And one thing I'd like to say, sometimes when people see the part about navigating, sometimes that gets interpreted as you're going to be the driver just to take them to appointments, which is definitely not what we're talking about. But the importance of supporting someone to get the information they need to be able to get the care they need. And sometimes that may mean going with them. And you can do a lot of peer support if you're actually traveling either in a car or on public transportation with someone. And, you know, I don't want people to think that that reduces us to being, you know, a driver.
Any other thoughts or questions, contributions, things you want us to pontificate or share with you?
And the other thing I would just offer, since I was talking about this presentation in particular, and this like being funded by a grant, and the grant you have with this integrated care team, often doing a small project as part of a grant is what then can turn into a funded service beyond that. And that's where like getting like this creative funding, like, and it's possible, is it possible to partner say with a university research or something where you're actually providing peer support, but it's for a limited time with a limited group. But once you show the results, then you can use that to get funding from the county or the state or.
Okay, well, this presentation is going to kick off the next few weeks focusing on physical health and wellness. So I just want to let you know what we're in for. Over the next couple of weeks, Lynn and I are going to be sharing with you a couple of different curriculums. One is called the New R, which stands for Nutrition and Exercise for Wellness and Recovery. We'll share with you the curricula, the manuals, information that you will need in order to be able to support people either individually and in group settings around that particular curriculum. We're also going to go through WHAM, Whole Health Action Management Plan, and we're going to have Peggy Swarbrick come and talk about wellness coaching. So she is the researcher that has done a lot of work around the 8 dimensions of wellness, wellness coaching, and she is going to be joining us probably, I would imagine, maybe in 2 or 3 weeks. We're trying to figure it out with her schedule. And we're also going to go through a diabetes self-management educational curricula that, again, as peer support specialists, we can take on, we can learn ourselves, we can utilize, and we can do it both individually as well as in group settings. We want to make sure that you have as many tools available to you that you can use, and you pick and choose which tool is right for what situation, what person, what resonates. But we want you all to feel as prepared as you can in your professional toolbox to pick these things up, including the PCORI studies and knowing some of the manuals, some of the data around the impact of peer support on physical well-being. We want you to have all that knowledge and all of those tools so that you can be advocates and support other people in their wellness. So I'll just pause lastly, see if there's anything else from Martha, anything else from Pamela, or from the group that we want to cover before we bid you adieu and end for our Friday.
I just want to say thank you for having us. And, you know, I think one thing I take from this with these research studies is I still get asked all the time, well, that's nice, but where's the evidence? Mm-hmm. And, you know, I used to say, right here, you're looking at it. I'm the evidence. But now there is a lot of evidence that what we do, you know, is unique and it improves outcomes.
Okay, I would just like to say thank you so much for to Shireen for allowing Martha and myself to present on this topic. I'm just grateful that we were able to do it when we have, which is today, and very excited to know that Peer Voice North Carolina has a team already looking into integrated health. You're working on it, and more trainings, lunch and learns are going to be presented on this topic. I have had the honor of participating on some of the initiatives that's going on. And, you know, I just know that PRN, Peer Voice North Carolina, is going to do the right things for the right reason. And I was listening to you as you spoke about that we don't want the peer support specialists to become many physicians. And, you know, by me working for several different providers in the community, that's exactly what would happen if we didn't have a program, Peer Voice North Carolina, leading this up to ensure that the peer support specialist is respected and we do operate in our field. So thanks again for all that you do.
Oh, thank you so much, Pamela. That's, I'm humbled. I appreciate that a lot. Wonderful. And thank you all again for choosing another Friday with us. We are going to continue down this particular topic area. With that, have a great Friday and have a wonderful weekend.